This week on the BackTable podcast.
The queue of patients was always out of the door. I was always running late. People were always inconvenienced by having to come into my clinic, and I thought that contemporary technology was at a point where we could automate a significant amount of that activity, specifically the clinical activity that clinical professionals were doing, the low-value activity, and that would free up people to do more complex things with their time, provide greater convenience for patients, and it would reduce the cost to healthcare services as a whole.
Welcome to BackTable Innovation. You can find all our previous episodes on Spotify, Apple Podcasts, and at backtable.com. This is the next installment of BackTable Innovation, where we learn from physicians and entrepreneurs working hard to drive healthcare forward. My name's Deanna, and I'll be your host this week. I'm a physician and biomedical engineer in London, joining BackTable to bring more European voice to the show. On today's episode, we'll be welcoming Nick to Pennington, a neurosurgeon, CEO and founder of Ufonia. The team at Ufonia have developed a telemedicine solution that's able to follow up patients after uncomplicated surgery. I'm very excited to learn more about this elegant example of artificial intelligence in action. So Nick, great to have you on the show. Why don't we start and you just introduce ourselves to our listeners?
I'm Nick to Pennington. I'm the founder of this company, Ufonia, but from a clinical standpoint, I was a surgeon. I was a neurosurgeon working in the NHS for the best part of a decade. So I did all my training around the kind of Oxford area before transitioning across into the world of digital health.
So tell us a bit more about Ufonia. What are you guys building?
Well, as you say, we're building a platform to automate routine bits of clinical care. So I sat in clinic, like I guess many of the people listening to this podcast, and thought that a huge amount of what I was doing and what my colleagues across all sorts of specialities and disciplines were doing was really routine activity. Yet the queue of patients was always out of the door. I was always running late. People were always inconvenienced by having to come into my clinic. And I thought that contemporary technology was at a point where we could automate a significant amount of that activity, specifically the clinical activity that clinical professionals were doing, the low-value activity, and that would free up people to do more complex things with their time, provide greater convenience for patients, and it would reduce the cost to healthcare services as a whole, which, given the current economic conditions, is vital everywhere across the world.
So what can Ufonia do? Just so our listeners understand, what kind of patients can it follow up? I know it's hard work running a clinic, but I guess there's some parts you can automate and some parts you can't. And I'd love to hear, your experience of how you moved that forward.
Yes. We started with the most common operation in the world, which is cataract surgery. It's an area that causes significant operational pressures to all healthcare systems. And specifically, we started with the follow-up after cataract surgery. So the surgery, as most people will know, is pretty straightforward, very safe, and patients have a generally really great outcome. But it's worth checking to make sure that they haven't got any complications or any other issues that need to be resolved afterwards. And so depending on the health system you're in, people are seen 1, 2, 3, or even more times after surgery in some countries. And these are really routine consultations. And so what we do is, rather than a patient coming and being seen, or even nowadays having a telemedicine visit, our system, which is called Dora, telephones people, has a conversation with them, and is able to recommend the next steps in their care, which could be to be discharged and to go and see an optician and get a new pair of glasses, or it could be to come back and have another operation on their other eye, or it could be to come back because they mentioned something that we think needs a human clinician to look into more detail.
And how does it work? Is this like, does Dora have a conversation with the patient? What does it feel like from a patient perspective?
Yeah, exactly. I think the thing to remember, which we sometimes forget, I think, as clinicians, is that a consultation is a bidirectional thing. There's a lot of digital health tools that are providing one side of that experience. So some tools collect information from patients for the benefit of hospitals or clinicians. And some tools allow patients to contribute information and to share information or to ask questions of their healthcare providers. But what we're doing is combining the two things together into a bidirectional conversation. So the start of the conversation involves asking the patients things to make sure to take essentially a small mini history from the patient. And then it transitions to allowing the patient to ask questions. And then bringing all of that together, we're able to offer them some guidance on the next steps in their care. But we also capture other information on the call, such as their experience. And we also capture information about feedback they want to give to the hospital team. Because, as I say, cataract surgery and lots of these elective surgeries where we're starting, but, people who are absolutely delighted having had that. And we want to be able to feed that information back to clinicians on the front line. It's a tough enough job, but we want to be able to let people know that their patients are really grateful, even if they're not seeing them themselves.
No, that's great. I imagine that not running clinics might affect some clinicians in that way. They don't get that feedback. So you said there it feels like a conversation. So the patient sort of has a conversation with Dora. How long does this last? Is it like a 5-minute conversation? Is it very patient-led? Like when you listen to the recordings, how do people interact with Dora?
Most of the conversations are about the 5 to 10 minute length, and that's kind of optimal for us at the moment. It's a signifier that these are relatively straightforward conversations. But the really interesting thing is we haven't got a limit. So it doesn't matter how long the patient wants to speak to Dora. Our system can speak to the patient for as long as they need to. In contrast, I guess, to, what we typically and colleagues will face in clinic where, you're on the clock in terms of trying to move through all the people that are booked in. So that's, I think, one of the real key benefits. And the first thing that we did, and the first study that actually just got published a few weeks ago, was all about patient acceptability. And I think the really interesting thing about the cataract patient cohort that we're looking at, their average age is 76, just the natural history of the disease. Typically, those wouldn't be people that you might say are early adopters of AI technology. Slightly generalizing, but, as a whole. But yet, what we see, incredibly high net promoter scores, averages of 9 out of 10 across the sites that we're deployed in, because we're providing that kind of convenience of the system. Dora calls them when they're told Dora call will happen. Dora can speak to them as long as they need to. There's no rush. And even the calls can be done at different times of the day or different days of the week in a way that human staff, just don't have the capacity to offer.
So one of the things that I find really impressive about Ufonia is that, you're delivering this AI technology directly to a patient's telephone, right?
Yeah.
I think that's what makes it so easy for, someone that's 76 to adopt the technology. They don't need to interact with anything. They don't need to, go through some complex API to access a chatbot and get frustrated by it. It's just a phone call. Nothing changes. It actually just makes things a lot easier for them. Tell me a bit more about how the technology works. What's behind the technology at Ufonia?
Essentially, exactly as you say, in front of the curtain for the patient, there's no technology. And I think that's the really important thing to emphasize, that the patient just has a telephone call on whatever line. Behind the curtain, there's lots of different things happening at the same time to try and orchestrate essentially a real-time live telephone call with an automated agent. So to kind of summarize, of course, we have to connect into the hospital record systems to get some information. We then need to deliver calls out across the telephony network. We take audio across that call, which is usually relatively poor quality, and need to transcribe that into text. We take that text, put it into our conversation engine that essentially decides what's the next best thing to say to the patient. We generate that live, turn it into audio, feed it back down the phone, and the patient hears it. So all of that's happening in real time to try and deliver a natural conversational experience.
So this is sort of an example of natural language processing, right? Taking audio, moving it to text, and then your algorithms will then pick out the keywords in text to form an appropriate response.
Yeah, exactly. So we're trying to understand from whatever the patient says the intent, and those intents then will trigger different utterances from the system depending on what we can understand from the patient. As you can imagine, part of the complexity of this as well is doing it in a regulated way where there's a degree of explainability about the natural language processing that's going on.
How have you guys gone about that? I know that explainability in AI is a big, big topic. Probably could talk about that for an hour, but in the context of Ufonia, I guess it's for a very specific application. So maybe it's a bit different.
Yeah, it is. I mean, I think it's a general concept, right? We're a bit different from the sort of image detection type AI, but explainability in our context is, I think, a combination of clinical safety and the underlying conversational architecture that we develop. And so we go about developing conversations. So as cataract was the first use case, but we're now building that out into all sorts of other similar high volume care pathways. And we go about that with a kind of the standard evidence-based method that you'd expect for any kind of healthcare solution. So we do a literature review. We source information about what is the content of a clinical conversation. we think is discriminatory in terms of whether someone's well or unwell, effectively, or has a particular symptom or doesn't. We then kind of build that with some key opinion leading advisors. And then really importantly, we go and test it with people, with real members of the public, and see how they respond to the conversation and see what they say, and then use that to train the system to understand people better, to reach a point where we have confidence that what the patients are saying is something that the system understands correctly and reliably and reproducibly. And then we'll move people through the pathway in the way that we think is safe.
And how was it, like you said, that, you go through this whole process to find the parameters of someone who's well, someone who's unwell. But I imagine there's a lot of nuances in the way that people say, I have eye pain. They might say that in 25 different ways where only one is relevant. Would you follow up sort of anyone that says they've got eye pain? What
we're doing is we're sort of doing medical school 101, taking a history from a patient.
Okay.
At a high level, that's the fundamental concept of our system is, we're all taught on week one of medical school that taking a history is 80% of the process, right? And then, the examination kind of confirms your history, and then the investigations kind of confirm your examination. But the history and speaking to the patient is the course. And so that's our premise, is that speaking to patients, we can gain the majority of the information that we're going to need from them. But you're absolutely right. People say things in different ways. I think there's two elements to how we solve that. So one is the underlying base level of natural language processing kind of research. And that continues to progress. And so we use some underlying large language models that have been well developed and described to kind of understand the core things that people say, that the fact that yes and yeah and all kind of mean basically the same thing.
Yeah.
But then we kind of put a layer on top of that that's healthcare specific and that's domain specific to the area that we're talking about. So, in cataract surgery, there are things called flashers and floaters, in terms of symptoms that people get. Now, that's not something that kind of features heavily in the standard language models that are trained on, the whole of the internet. So we've got to then finesse that input to try and make sure that the system understands they're a particular class of symptom that we care about and that we want to pick out with high reliability. And so that's that process of kind of moving it through training before we put it in front of people live.
That makes a lot of sense. And I imagine the more sort of niche you get into a particular, or the more
specific, domain specific.
The more domain specific you get, the more difficult it is to quantify or categorize what the patient's feeling. And the reason I ask about pain is because, in my experience, I've worked in East London a lot, and people don't use the word pain to describe them being in pain. They'll go for burning, they'll go for tingling before they'll admit that it's pain. And I just wondered if maybe you'd had a similar experience with the nuance of that word.
Yeah, for sure. I give a kind of a simple example, but it's if you ask someone, which is one of the core things, is your eye red? Well, people can describe that in a whole heap of different ways, right? Rather than what you're describing as a clinician looking at the eye. So that's, as you say, exactly the kind of thing that we're trying to tease out. The other thing, you mentioned East London, the other thing that's kind of super interesting about the system is the ability to cope with people with different cultural experiences, which is somewhat about how they would express themselves in English, but also in different languages. So we've got some really exciting work where we're collaborating with some international sites. So a team over in Holland and the Netherlands and a team in Hong Kong. And we're able to deliver the system in multiple languages, but we're just going through the process of trying to validate that in the same way that we have done in English in the UK before that starts getting used by patients in those countries and elsewhere.
And I can see that being of massive value, especially in areas where, you've got a really broad demographic, and doing a clinic with a translator is no easy task, as I'm sure many of our listeners understand. So bringing it back to the clinic setting. So you mentioned, you've got Dora. So say I'm an ophthalmologist. I've done 100 cataract surgeries that were uncomplicated, and Dora has called them back. What kind of proportion can I expect Dora to discharge versus Dora to sort of send back to me?
At the moment, we're a kind of version 1 of the system, which is a pretty high bar for us considering the patient to be safe. And so even with that, we're able to discharge 60 to 65% of people pretty consistently across every setting.
Wow.
Which from an NHS clinician standpoint, the NHS at the moment is trying to reduce routine outpatient appointments by 25%. So we at a stroke are able to identify more than double that number of patients who could be discharged and therefore freeing up capacity to see people who need more complex care.
60% is huge, right? If before I had to do clinics 5 days a week, now I only have to do clinics 3 days a week. Dream.
And that's exactly what's happening. Those doctors or those nurses or those optometrists are free to see people with glaucoma where they need to see them and they need to measure the pressure in the eye. It's really powerful. And as I say, this is version 1. We're really cautious about, so anyone who has any issue, who has any questions that we can't answer, we don't have high enough confidence in what we've heard or the system's heard. All of those people are in that 40% or so who get a second line human review.
Yeah, and it has to be that way, right? Because otherwise you need to get buy-in from patients, but also from clinicians. How has that process been? How has it been getting buy-in from clinicians? I imagine very easy.
Yeah, exactly. It's actually that. I think, people from the outside of medicine say, oh, you're never going to convince clinicians that an automated system, a robot in inverted commas, can deliver their care. And actually, I think you couldn't be further from the truth. Most clinicians realize that a significant amount of what they're doing is pretty routine stuff. It's activity that's kind of burnout inducing activity, right? It's repetitive. It's really stereotyped. One of our biggest problems, which is a great problem to have, is every clinician we speak to has a use case in their specialty where they're doing something that's high volume and repetitive. And so, my biggest challenge most days is saying no nicely to people or saying not yet, because, we want to make sure that we consolidate the first use cases we've got and make sure that they're really excellent experiences before we spread out too thin to do too many different things.
And it's so important, especially in healthcare innovation. If you lack that focus and you try and spread yourself too thin across too many applications, then you won't hit any of them.
Yeah.
What's next? Just out of curiosity, what's the next most compelling use case for Dora?
Well, I mean, the UK and the NHS has done some really great work. There's a team called GIRFT, Getting It Right First Time team, who've really sort of led the way in kind of standardizing pathways. And in particular, they have a high volume, low complexity pathway group. So we're really following in the wake of that activity. And so essentially what we care about doing is moving the needle for healthcare systems. And so we care about things that are high volume, that are causing pressure on the systems and making patients wait for longer. And the things that we're building now, we're building for orthopedics, for hip and knee replacement surgery. We're doing some work in ENT, head and neck cancer triage pathways. A huge number of people coming through those pathways. The overwhelming majority, 95% plus, who don't have cancer, but yet are still struggling to be seen in a timely fashion. But we're also doing some work in women's health, so gynecology, the hysteroscopy pathways. They're just the tip of the iceberg. Anything where people are having high volume conversations, that's the sort of activity that we're trying to automate.
And what has your experience been? Because I guess with the cataract surgery is a lot about patient follow-up, but I imagine the conversation becomes increasingly complex when you're trying to triage someone, especially on something like a 2-week wait pathway. And for the benefit of our American colleagues, a 2-week wait pathway is an emergency sort of care pathway where you're seen within 2 weeks when there's a possibility of a diagnosis of cancer.
Yeah. The challenge is more at this stage because, again, it's pretty standardized. And actually, the work we did in head and neck cancer is with a team at St George's in southwest London. And nationally, a group of ENT surgeons were very progressive in terms of trying to establish a standardized way of triaging people, a standardized questionnaire. And this was introduced by their trainee collaborative during the first phases of COVID as a way of trying to optimize the way of seeing people who came through a 2-week wait pathway. So it is a bit more complicated. The greater complication is actually the operational delivery. So I think we're always very mindful of the fact, and I think I skipped over maybe at the start, my career journey sort of spanned from delivering full-time clinical care to then delivering some digital programs from within the NHS. And what I recognized in doing that was if you ask people to implement a digital solution and you ask them to change their pathway to accommodate the digital solution, those two things don't go well together. And generally they mean that the digital solution doesn't work or takes a long time to implement and people are pretty annoyed.
Or the technology becomes outdated before you get to hit go.
Yeah, exactly. It can never deliver what people want. You're always kind of forcing people to change and compromise. The key about what we do is we say, look, we're just going to deliver a like for your current pathway. But what that means is we have to work really hard from an operational standpoint to make sure that we just sit into that pathway without people having to change and do things to meet what we want. We meet what the clinical teams one. So the complexity of that 2-week wait work is all about trying to sit into a pathway that already exists rather than make the pathway change to fit us.
And that makes a lot of sense. That's the only way you're going to reach the patients, and it's the only way you're going to be able to validate that it works. The pathway service change can come later. So, you mentioned the beginning of your career a bit, and I'd love to get to know sort of your story a little bit better. So you mentioned earlier you did your training in the NHS, you kind of completed your training. Is that right?
Yeah, so I went through the full residency program.
And what happened afterwards? I know that you do a lot of work in sort of health data structuring and digital health solution. Well, I guess working on the infrastructure behind digital health. I'd love to know a little bit more about that.
Yeah, I mean, it's a sort of, as with everything, sometimes on these kind of interviews, right? Everything's kind of rose tinted.
Yeah.
And it always is a bit rose tinted, like the kind of story. I have to say, for all those clinicians thinking about how do they merge kind of digital or technology and entrepreneurship and clinical practice, like this was a very organic journey. So the only thing I had planned is that I knew I wanted to be a neurosurgeon, right? I went through and into a neurosurgery training program straight out of my basic surgery training. And I was convinced that that was what I wanted to do. And it was super interesting. Like I had hopefully delivered some value to society, was able to care for a bunch of people who were really sick, was able to do some very interesting kind of operations. But fundamentally, I kind of realized that it was pretty unscalable. That if I wanted to have impact on sort of wider society, doing 1 8-hour operation a week was probably not going to be the way to do it, although it would help that one person, hopefully. So I got really interested in value-based healthcare. I went on Michael Porter's course at Harvard Business School and got excited by the potential of using technology through some of the case studies there to affect scalable change. And so to cut a slightly long story short, ended up building some digital solutions from within the NHS in a hospital in Oxford. Found that really hard to do. So along with a couple of great colleagues, we set up an innovation program within the hospital to try and make it a little bit easier for other people coming after us. And that's thankfully been adopted by the hospital trust there as their formal innovation program run by a great team now. And when I got to the end of my residency, my registrar training, I essentially transitioned across and started working from the management side of the hospital, kind of trying to support and run those innovation programs and got given some responsibilities to try and run some other digital programs that, as you mentioned, involved rolling out integration of data, population health solutions. Did that for a short while, but the realism of how difficult it was to do things from the inside that were innovative, dawned on me pretty quickly. And I thought, if I want to really do this, I've got to do it from the outside.
So you said that, you finished your residency training, you went into this data management. And how was that transition towards Ufonia? Where did that idea come from and start?
I actually won a hackathon competition.
Oh, wow.
With the original idea from Ufonia, which is basically not very different from what we've kind of implemented. And that gave a small kind of grant, £25,000, I think, to build the initial prototype of the system, or a prototype. And so built that concept that we could autonomously call people and have a conversation with them in a bit of a Wizard of Oz system. So it was, the front end seemed like that, but behind the scenes, we were doing a lot of manual stuff.
Frantically, everyone was searching for words.
Yeah, literally that. There was someone sitting, listening into the calls, like clicking on buttons to kind of classify what they thought the person had said, and that would spit out something different to the patient. But it was a way, I think it's the kind of classic now way of trying to do technology software development, right? Is, create an MVP, get it in front of users really early on. So we had a great GP up in Liverpool, like right in the very earliest days, who said, oh yeah, like I need this for all my patients. I want to call all my patients on my entire list every year and find out if they're okay. Because at the moment I don't see, 70% of them from one year to the next. So he was like, yeah, this is brilliant. Look, here's my patient, access group. Let's put it in front of them. Let's ask them if they'd like to try this out. So we just got the broad principle in front of some real patients from literally day one and got some feedback from them about like what they thought about it. The AI bit of it wasn't like working behind the scenes.
Yeah.
But the kind of concept and the experience, was there. And I still remember like the first call that we did to a person and we were all sitting in this room listening in on the call and we could hear, and it works. And it was, it's one of those kind of like light bulb moments. You're like, aha, this definitely is going to work. People get it and they were able to interact with it in a really, really engaged way. So yeah, that was the really powerful.
And that's a better way to do it, right? Then you're really addressing like a true unmet need before you try and reinvent the wheel. That must have been pretty amazing. And who gave you the best kind of feedback? Was it the younger patients, the older patients?
No, well, we deliberately did this testing with some old patients because we knew that, it's a truism, right, for healthcare, but the biggest users of healthcare everywhere in the world are old and, I have to say, poor people.
Yeah.
Right? But, predominantly, like, health deteriorates with age. So biggest demand users of healthcare are more elderly people. So we always have, designed for that demographic predominantly. The system work with anyone, but we always know that like our target group are going to be people who are generally going to be 60 plus for most diseases that are being cared for in whatever health system in the world.
No, I really like that. It sounds like you guys have always had a very principled approach, and that's really hard to achieve, right? People get excited about tech. People get excited about the latest development, the newest software available, but they don't really contextualize it in a real clinical problem, which just sounds like you guys have done from the beginning.
Yeah, well, I think that's what like the massive advantage of clinicians, having clinicians involved in any kind of technology project is because you intuitively are able to, understand the need, we're trained to have a degree of understanding and empathy with our users, our patients, right? And so you really can kind of bring that to bear. And I thought, I trained in hospitals that were affiliated to big universities and saw, like, universities are amazing. They do great research work, right? But generally what I saw a lot of was hammers in search of nails, right? So people had lots of brilliant like innovations, then trying to find a practical problem that they were going to solve. And I think, if you come from within the system, you know what the problems are and you just have to try and work out how to solve them.
Yeah, most importantly, I think clinicians are really good at just stating the problems in simple words, right? They don't need to add flowery language to it. Like quite often the hardest things are just, I need the medication at 8 a.m. versus I need a very complicated medication.
Yeah, although it's I think it's what has only become apparent to me sort of with the opportunity, and I see it as that to step back away from healthcare. And it's what I tell everybody on our team when they join the team. It's like, you'll become immune to all of the things we're doing wrong, like after about a week. And clinicians, I think, you become immune to all of the, like when I look back, I think, why the hell did I spend 5 years like practicing like this? This is so inefficient. This was so bad for the patients, but it's the norm. So it is like really important to have kind of confidence of your convictions. But, and I think periodically to sort of step away to see the perspective, because especially when you're kind of in training, you're so head down, trying to do things, trying to progress, trying to learn new skills, that it's sometimes the case that you don't have, or, very few people, and I wouldn't put myself in it. Like I had to kind of step out to really see it, but like, very few people see these opportunities because this is just how we do things around here, becomes the attitude too easily.
Yeah, it's very hard to separate the noise from what's important. And what inspired you to take that step away? Was there anything in particular?
A mix of things. I kind of describe it, I think, as a bit of carrot and a bit of stick. As I say, I enjoyed the operating of neurosurgery, but I realized that to be a really amazing, what I liked about neurosurgery was like it's tremendously varied. I operated on everyone from preterm babies to 100-year-olds, on people who are about to die, in the middle of the night, to people who are really well. And it was just a very lifestyle. I really enjoyed having that breadth and spectrum of activity, but I knew if I wanted to be a really good clinician, I needed to just get really narrow and do high volumes of pretty much the same thing. And and it's not really what excited me about.
Yeah. And I think a lot of our listeners can relate. Some people enjoy that, but we're all different. And sometimes it's more about taking the innovative approach and understanding, taking an outside view to the hospital.
Well, I think it's also about kind of and it took me a while, right? So I went all the way through this training. And so it's like, a lot of people looked at me kind of pretty strangely at the end, having sunk all of that cost, if you like it, into what I see as sunk cost into neurosurgery. But, recognizing what motivates you as an individual. And it's really hard, again, in clinical careers where there's a pretty prescribed track that you're on. So yeah, the more perspective you can get on it, the better, I think. But yeah, I just thought, this is good, but like there's more to have direct clinical care.
Yeah. And look, what you guys are doing at Ufonia is affecting lots of patients. More patients will be able to have cataract surgery. And to your point, on other patient pathways, you'll reach thousands at one time.
Yeah.
and at the same time free up those clinicians that do love doing the procedures to do more of what they want to do and get better at it. So you affect both sides of the pathway.
Absolutely. Yeah, I'm pretty sure that in the last year, we've cared for, in our own way, more patients than I'd probably care for in my entire career if I'd stayed in neurosurgery.
How did you go about finding the other skills for so we talked a lot about the clinical skills and defining the unmet need and taking that forward to an MVP. But how did you get away from, the Wizard of Oz curtain? How did you find the engineers and the people who were able to build the technology and help with the business development side of things? I think that's something that a lot of physicians really struggle with. Where do you look for that talent?
Yeah, I mean, I was lucky. I was always sort of somewhat technical. So I kind of had enough technical digital knowledge to be a little bit dangerous. I'd done that from before medical school and through medical school. And I ran this project internally while I was still a trainee that managed to build a kind of platform for managing referrals from within the hospital. And so I kind of had enough knowledge about the technology just to know the right questions to ask rather than maybe to build it all myself. But as I say, I was very lucky when I got that initial grant. We went to a digital agency, to build this proof of concept. And the guy that ran that project is now our chief product officer, James. And he built that initial version of it. And then when I got some further funding and money, and I went to him and said, do you know anyone who's got your skill set who'd be quite interested in this project? He thankfully said, yeah, me. And so, yeah, he came on board, and that was the start of the team.
But there's no easy path to find those right people.
No, you definitely need people who have the skills. I think, I've seen some people, outsource it. I think that can work. And we sort of did that at the start just to get going. Mm. But you pretty quickly, if you want to be a product focused company, then I think you need to kind of bring that in-house. And I mean, nowadays I'm seeing a lot of clinicians. You don't have to be just in the lane of clinical practice. People on our team who are clinicians and are, really good at coding. One of our teams built some robotic process automation from scratch, literally written the Python code for it to do work that, people who are doing that across the NHS aren't even able to do. So you can be multidisciplinary, but one of the key things I've then said is you've got to focus on what your peak skills are. Don't try and just average out and be averagely good at lots of things. Don't be an averagely good clinician, averagely good kind of business manager, and an averagely good coder. Really choose something to focus on and get really, really, really good at something, because that's where the value, I think, comes.
No, that makes a lot of sense. And what advice would you give to clinicians that have an idea? They've put it on a piece of paper in 5 words. Where should they start? How can they go from 0 to 1?
Assuming you want to be an entrepreneur, I think there's a few assumptions to try and work through. Do you want to be an entrepreneur, or do you want to be a clinician?
Yeah.
So there's this binary thing of if you want to be a clinician, then you probably need to find someone who's going to take that idea on. If you're interested in being an entrepreneur, which I highly recommend, it's really exciting. It's does fulfill all the tick boxes for an interesting thing to do with your life. Then the most useful piece of advice that I got was through an accelerator program we were involved with from a professor of entrepreneurship, which sounds a bit of an oxymoron, but anyhow, this guy's
it does.
Yeah, this guy's advice was, the single necessary condition for a startup company is a paying customer. So I would strongly recommend you find out who is going to pay for the thing that you've built, and that could be that a charity is going to pay for it, right? It could be that it's going to be paid for out of voluntary donations of people's time, right? That's still plausible, but generally that's going to be someone has got to put their hand in their pocket and give you cash for the thing that you're going to provide. And the second most useful piece of advice I got was from one of our investors when we were kind of evaluating the system and we were testing it. And he basically just said, get out there and sell this thing, because sales is product discovery. If people are buying it and paying for it, you've got a solution that's right. And the more people that are doing it, the more right you are in terms of that you're building something that people want. And the converse is if people are not paying for it, you're not building something that's valuable to people. Therefore, you should try and work out what is. So I would really focus on that, because you can get a bit caught up in the idea, but it sounds really great. It's going to be kind of transformative, but that will turn to nothing unless you work out that it's valuable to people. And our economy, that generally means that people are going to pay for it.
I like that. 2 very practical steps to take. I'd love to know, how can people get in touch with you if they want to reach out, to learn more about Ufonia, get involved in some projects you're doing? What's the best way to reach you?
they can email me, they can LinkedIn connect with me, send me a message, I'll respond. But yeah, always keen to kind of talk to a lot of our good clinical areas have come from clinicians coming and saying like, this is where we've got a need. And I know neurosurgery and I vaguely know some of these other things, but I don't know, I'm not an expert in any particular specialty. So we really want people who are going to say, actually, this is a massive high volume pathway where we're doing the same thing day in, day out. And then the next generation of what we do is, at the moment, we're doing reactive care, but the next generation is to start to do proactive care. So although at the moment it's kind of predominantly hospital-led elective surgery work, the next generation is to think about how do we manage people's wellness at home through automated calls to them. So yeah, lots of opportunities for people who have insights into that area come along, and we'd be delighted to talk about it and potentially work together.
That's great. And what about any recommendations of any books to read or anywhere where we can learn a little bit more about whether it be natural language processing or, the principles of entrepreneurship that you've touched upon a lot? Yeah,
the principles, I don't think there's anything better than getting there and doing it. It's really hard. You can read as much as you like, and everyone can read all of the kind of the classic books about lean startup and everything else. But ultimately, and again, it was something I was pushed to do by one of these programs. Is you've just got to kind of pull the ripcord and have a go. The amazing thing about being a clinician is you've got this amazing safety net. There's never a shortage of jobs for you to go back into, and I think increasingly the skills that you get are going to be massively in demand anyway. So I don't think anyone should think that this is a detrimental career move to do it. So yeah, I think the most important thing would be to get involved. We kind of run within the company something that's kind of pretty classic and would be very recognizable to clinicians. We run a journal club series. We run learning sessions within the company, and I get all of my insights from my colleagues. My kind of answer to your question is meet other people outside of medicine, who can give you those insights and who can say, actually, look, this is an amazing paper that's been published, or here's, someone who's really sharing interesting blog posts, or, this is a company that's in an exciting space. So the only way I think to do that is you can't do it on your own. You have to basically do that either with a team that you bring together, or, if you're starting out, really network, but try and force yourself to network outside of the common circles of the usual clinicians.
Be curious, take risk, and hang out with other curious people. It's very important.
100%.
Couldn't agree more. Yeah, and there's no better learning than experiential learning.
Yeah, definitely. Just got to do it, and then you find out, right? It'll go one way or the other, and you'll learn a lot either way, right? So just do it.
Great. Well, thank you so much for coming on BackTable. It was fascinating to hear more about Ufonia and learn about this elegant solution of artificial intelligence in action. I hope our listeners found that useful, and we look forward to seeing where you're going.
No worries. Great to be here. Thanks.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at BackTable Innovation on Instagram, LinkedIn, or Twitter. BackTable Innovation is produced and hosted by Brian Hartley,
Aaron Fritz,
and Eric Yamaker.
Our audio team lead is Kieran Gannon, with support from
Caleb Hodson,
Josh McWhirter,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Ann Dang. Social media and PR by Chi Dang.
And Dana Parker.
Thanks again for listening.
See you again next week.